Good afternoon. It is my pleasure to welcome you to GW Resiliency and Wellbeing Center Women's Wellbeing Lecture Series, brought to you by generous support of Dr. Rosemary Bose, PhD, whose endowment fund is dedicated to support women's well-being here at GW. And today we are talking about cardiovascular disease in women. And our wonderful speaker is Dr. Icilma Fergus. She is a board-certified professional in internal medicine and cardiology, and currently serving as a director of clinical lipidology in the Division of Cardiology and Cardiovascular Disparities at Mount Sinai. Her expertise lies in preventive cardiology, specifically focusing on lipids and hypertension, women's heart disease, and cardiovascular health advocacy. With an active engagement in professional organizations, Dr. Fergus holds significant roles, such as the past president of the Vice Board of the American College of Cardiology and the past president of the Association of Black Cardiologists. In addition to that, she's also a dedicated member and the past president of the Jack and Jill of America Foundation. Beyond her professional commitments, Dr. Fergus passionately advocates for health equity and cardiac disease prevention. Her impactful contributions have been recognized throughout numerous awards, including the Luminary Award from the American Heart Association, the Community Service Award from the Heart Valve Society of America, Young, Black, and Gifted, and Community Award from Delta Sigma Theta in 2023. In addition, she has been featured on numerous publications and broadcasts, including Here and Now with Sander Bookman on ABC. So with no further delay, let me give Dr. Fergus a stage. We are very excited to have you here.
Certainly, and I'm very, very excited to be here this afternoon speaking to such an illustrious establishment. I am excited. Thank you so much for having me. And, hope to impart some information that you find helpful and, also, have an engaged, discussion. So before we get started, I don't know if I can see the chat. I'm sometimes a little bit challenged with, with technology, but can people just place in the chat what type of provider are you? And I don't know if I could see that, but I'd just love to see the the sort of demographics of who am I speaking with. So what type of provider are you, and how what are you doing currently, so that I kind of get to know my audience. So, okay, I see captain's a digital hygienist, counselor, librarian, yoga therapist. Okay, psychologist, excellent. Anybody else? Researcher and educator, excellent. Just researcher, okay. That was Carol. Excellent. Perfect. Okay, so retired engineer, I love that. Okay. Well, okay. The next question is, if you're a male, put yes, male in the chat, so we just know our audience. So is it all females? Okay, so we're all women on the line. Okay, that's fine. I always say women are not little men, so we want to make sure that we understand not only our presentation, but our anatomy, how we present differently, what the symptoms might be. So I see we have a very varied group of individuals, and I want to make sure that I tailor my talk so that everyone can get something out of it, but that, I'm, not too technical. So my task today, I wanted to share, let's see, can I move these slides forward? Okay. Okay, So I wanted to talk a little bit just about the prevalence and presentation of heart disease in women and talk about some risk factors or contributors that are very specific to women, including specific conditions that we may face that are a little bit different, and what are some tests and how may we manage that may be different, than how men are managed. But first, let me just say that despite the fact that it may not be first on the mind of every person walking around, there are more than 60 million women living with some form of coronary cardiovascular disease. We know that there's been a decline in death rate, but then we saw it sort of decreased, and I'll show you in the next slide. It decreased and it's up again. And so we need to make sure that we do not reach the high levels that we reached before, because cardiovascular disease specifically in terms of death is the third highest death that we specifically encounter in terms of all the heart disease deaths. And only currently about 1 in 3 women can identify that heart disease is the leading cause of death. And some of this data kind of lags behind, but I'm happy to say that heart disease is 80% preventable if you only kind of knew what to look for. But here on the next slide, the mortality trends, of course, lag behind. And this one, shows you the death rates. But I think very importantly, as you could see, the females, typically were, higher in terms of mortality relating to heart disease compared with males, shown in blue. And then somewhere around the early 2000s, there was a huge campaign that was undertaken by the American Heart Association, the NHLBI, and other organizations that, wanted to really drive home the message that women are truly, likely to get heart disease, have issues related to heart disease, and they really spent a lot of time really talking and sharing and educating in all walks. And as you could see, there was a tremendous decline in, the mortality rates for women cardiovascular deaths.
Dr. Fergus, I'm sorry to interrupt. We do not see your slides.
You do not see my slides?
No, we do not.
Okay, you're not seeing the slides. Let's go back. You're not seeing the slides. Can you, okay, so I'm going to end the slideshow right here, and I'm going to ask to share again, okay?
Absolutely. You should be a co-host of the meetings. Oh, here you go. We can see your screen
now. Okay.
We see your screen.
See my screen.
Yep.
Okay, are you seeing the slides?
Yes. Yes.
All right, so I'll just quickly repeat I'm not going to repeat what I said, but these are my objectives.
We are actually seeing the presentation or the presenter's view, not the full slide. So I don't know if you want to switch which screen that is.
I don't mind. I'm just going to leave it like this.
Okay.
As long as you could see it, that's fine. I think that, so this was what I was showing you about the mortality trends in terms of, where the campaign started in 2000, and where you see that the red line kind of goes down almost below men and starting to climb again as we, sort of relaxed on all of the education that has been undertaken by the NHLBI, AHA, et cetera. We're starting to see an increase again in mortality rates of women. So women still do not perceive heart disease as their major health threat. When you talk to women, they're more afraid of cancer in general, and still so even later on. And I know these slides are older, but this is an older, sort of study that was done by the AHA, and I think that it's so potent. It really hasn't changed to this day. You may see a little bit less in terms of the percentage of the women, but it's still where women mostly fear cancer and less likely to fear heart disease. But, we're trying to do a little bit better job of women recognizing that heart disease is the leading cause of death and not not cancer. We are seeing an uptick in cancer most recently, especially colorectal cancer for women, and we're seeing more diagnoses of breast cancer. However, women are not dying as much as they used to in the past. from breast cancer, but we're just becoming better at detecting whether cancer is present and, you know, kind of stopping it early in its tracks. But when it comes to women, because of the many different types of heart disease, a lot of it can still be missed. So let me just show you on this next slide, when looking at the most common cause of death. And again, this is from Heart and Stroke Statistics, a report for the American Heart Association. And looking at death rates all the way up to, you know, sort of 2018, 2019, we still see, if you look at the types of death that women are commonly dying from, and you'll see that on the left, any type of heart disease, so CHD in general, is the leading cause, followed by, you know, we see now we see the cancers all the way to the right is breast cancer, lung cancer, and stroke. I'm not going to be getting into disparities so much in this conversation, but you'll see though that there are disparities within this whole presentation where you're likely to see certain groups or certain populations of women have a higher you know, rate of, you know, succumbing to these types of deaths. So you may see Black women more likely to suffer, but as you can see, overall, heart disease is still the most common cause of death when you compare the other most common causes of death, breast cancer and lung cancer. So I just wanted to drive that point home. Now, you know, you've always heard, oh, women are protected from, you know, having a heart disease condition, and they don't get heart disease until you become menopausal. Well, that's a myth. You can have heart disease all the way from very early on in life, and it may be different types of heart disease, but you know, really, the typical heart attack that we talk about is the one that people most know about. And yes, as we get closer to menopause and we are no longer protected by our innate estrogens, because you'll find that external estrogen doesn't protect you and it may in fact hurt you. But when you get to, you know, sort of middle age-ish, then you start to have other things such as your garden variety heart attacks, you know, the blockages that, you know, you have to go to the cath lab and they open it up. But earlier in life, we're seeing women with arrhythmias, which are irregular heartbeats, and conditions of the covering around the heart and the heart muscle itself, such as pericarditis, myocarditis, and especially in the age of all the flus and the other viruses like COVID, we're seeing a lot of myocarditis. I was just sharing with Victoria before everyone got on the call. I just admitted a female medical doctor back to the hospital last night for shortness of breath, and she has elevated troponins, and she was admitted a month ago, presenting for all the world as a massive heart attack, and what she had was influenza myocarditis. So she presented with chest pain, shortness of breath, and the EKG looked abnormal. When we did the troponins, they were very, very abnormal. So it looked for all the world that she was having a massive heart attack. And how did we rule that out? Of course, you rule out ischemia by getting either a stress test or a cardiac cath, and it turned out that those were okay. She did have a weak heart, so based on her very high abnormal enzymes for the flu, that's how we were able to figure out that it was flu myocarditis, and the troponins became very normal after a couple of days of treatment for the flu. But, you know, you can see those types of conditions, and those are what you tend to see a lot more earlier on in when women present with, you know, heart conditions, but it's still present. It may not be more than men overall, but it's still present. So I'm going to later on show you some different types of heart disease conditions that can affect women, particularly emotional and inflammatory causes that we're seeing a lot in younger women compared with the older women. So yes, earlier on, the men may have more likely to have a higher percent of the population with the typical heart disease, but women can as well. Now, some of the reasons that women can be underdiagnosed or not diagnosed appropriately in when they present to the emergency room is that symptoms can be different compared with compared with men, right? So, you know, in the all the textbooks, obviously, the typical anginal symptoms are a heaviness on the chest, feeling for all the world like an elephant sitting on your chest or standing on your chest, and very heavy. And that's called angina or angina. And when that is present and associated with an EKG change, then, you know, people can quickly diagnose and say that, oh, this person's having a heart attack. However, women's symptoms can be very, very different. Number one, it could present for all the world like a cold, flu-like symptoms, or nausea, vomiting, cold sweats that are very different than what I just said. Stomach complaints, typically you may even feel fatigue, anxiety, loss of appetite, shortness of breath, pain in the upper back, jaw, or neck, very different than you would see in the textbook. The other thing is that many women, especially some of the older women that are used to being caregivers and caretakers, you know, they would be very stoic. So there'll be a denial of symptoms, or they're being, quote, the matriarch. So they're minimizing their symptoms. So that's one group that we see. And then you have another group that may be over complaining, so that the providers may not know if they should be taking these symptoms seriously. But regardless, all of the symptoms should be taken very, very seriously. And you know, people need to be, when they present, if you know that you're feeling a particular way and you're being dismissed, of course, insist that you need to be evaluated and not just sent out. Now, the typical presentation of ischemic heart disease, that's in the textbook. I described the chest pain, heaviness in the chest, and, you know, EKG changes. But now we're seeing some other conditions in women that have a different name. And I'll just tell you a little bit about that. So we have conditions where when these women are taken to the cath lab and they're getting evaluated, you're not actually finding any obstruction. And so you want to be able to make sure that these conditions, though, are not, you know, diagnosed. Now, this is called INOCA and MINOCA. So INOCA is ischemia without non-obstructive coronary artery disease, or ischemia non-obstructive coronary artery disease. MINOCA is a myocardial infarction with non-obstructive coronary artery disease. So a little different than, say, the flu myocarditis that I talked about before, where it's the entire muscle that's involved. Here, there's specific arteries that get involved, and they are impaired by, and I'll show you later what some of that actually looks like. And the person presents with elevated troponins, but when they go to the cath lab or when the arteries are looked at, they're not obstructed. And this represents about 5 to 6% of all acute myocardial infarctions. But when you look at women versus men, it's more likely to be the women who present this way without an obstruction, about 11% compared with 3% of men in general. Another thing that we see a lot now is you can see what we call spontaneous coronary artery dissection. This is one of the key components that would cause a myocardial infarction without a typical obstruction. So a tearing of your coronary artery, sometimes brought on by, you know, stress, older maternal age, and other things like that in women. I think there was a news anchor in Washington, D.C. who presented with SCAD, and luckily she's alive. But if it happens, especially on your left anterior descending artery, which is right in front, you could present with sudden death. Other things that can cause obstructive coronary artery would be like vasospasm, or small vessel microvascular dysfunction, or, you know, like a clot or a thrombus. So we'll talk a little bit more about that, but I do want to just share that many landmark trials were done. And I'm going to skip through this because I do have a lot to share, but these are some of the trials. You know, a lot of the trials are older trials, but you know, there are not many new guidelines that have been created on women, because many of the clinical trials are done in all comers. And as I said, Women Are Not Little Men, but there are not a lot of newer trials that are dedicated specifically to women. But here are some very landmark trials that you can reference if you want to look at, some of the things that we're talking about, like the Women's Health Initiative and the HERS trials and WISE. We got a lot of information from these trials that are very helpful. In the WISE, trial, women such as yourselves who were nurses or healthcare providers are the women that they studied, and also in the Women's Health Initiative. So I think these are some very helpful trials for you to, reference. From all of this work in Dr. Lori Mosca, we find out that some risk factors may be more important for women than men. And because all risk factors are important, but you want to pay particular, attention to some of the so-called newer risk factors, such as lifestyle, which includes, physical activity, obesity, the metabolic syndrome, inflammation, depression, and some of elevated inflammatory conditions, such as infections, where you can see elevations in the C-reactive protein, homocysteine, and LPL-a. We all know about the typical risk factors, such as premature heart disease, diabetes, hypertension, and cholesterol, and for women, particularly a low HDL. But it's important to recognize that these other risk factors are very important. And in fact, there are risk factors that are women specific because men can't get pregnant, right? So these are more important. And if you want to put in the chat, if you're under 50, put under 50. But these are some risk factors that have been associated with heart disease. So having an early menopause or having certain risk factors during pregnancy. I think that at some point you all, and you may have already have a specific, discussion about women during and around pregnancy, because we're seeing a lot of increased maternal, sort of comorbidities and mortality related to pregnancy. But pregnancy-specific risk factors are very important. So preeclampsia, which is related to hypertensive heart diseases, may or may not be related to hypertensive heart diseases, but typically that, and hypertensive heart disease conditions themselves, which are not preeclampsia. Eclampsia, you're already close to death where you may end up having a seizure, et cetera. But again, a lot of that has to do with elevated blood pressures, and then you have abnormal protein and the organs dysfunction. You may end up having, vessels that are constricted, leading to seizure and strokes during pregnancy, and gestational diabetes itself. Those are risk factors. If you have a small child, a small birth weight, that's a particular risk factor for heart disease. Having preterm delivery could be an issue as well. And so we'll talk about later, but getting an earlier coronary artery calcium score, if you have any of these risk factors for during pregnancy, can be very important. Now, here's what I was talking about when it comes to your blood vessels and having something such as we talked about before, ischemia or myocardial infarction without obstructive disease. So I just to remind you from before, things like coronary vasospasm, microvascular dysfunction, SCAD, et cetera. So this is what it looks like. There are several types that are more common here in women. So pretty much if you have a plaque, so you're building up blockages due to the fact that you have, elevated lipids. If the plaque ruptures and you have sort of, erosion of that plaque acutely, you may end up having ischemia or even infarction, okay? You can have clots that also form in situ. What does that mean? You may be hypercoagulable, and inflammation can lead to hypercoagulability. 2 weeks ago, I just admitted a young woman who presented with chest pain. Normal person, working out, she goes to the gym. She was 51 years old, but high-level stressful job. No reason to have clots. She did have an issue in the gym maybe about 5 or 6 years ago. Nothing was thought of it, and now she presents this way. I admitted her, and she turned out to have pulmonary emboli, a lot of clots. So clots can form spontaneously, and it could be in the lungs, but if it's in the heart, that could be a heart attack, and that can cause in situ thrombosis. SCAD, or spontaneous coronary artery disease, is a rupture, a tear of the endothelium, or the lining of the blood vessel. And when it tears, it can actually misfunction, and you don't have blood flow going to the heart. That can result in a heart attack. So any of these mechanisms, spasm, clot, rupture, erosion, or tear, can lead to a supply-demand mismatch where oxygen's not going distally to the organ, and you have a heart attack. All right, so on the left, you see what the mechanism might be, and on the right, you see what can be the outcome, where you end up having, basically no flow or low flow to the myocardium, resulting in ischemia or non-obstructive coronary artery disease. I just wanted to share 1 or 2 slides about emotional wellness, and I can't get very deep into any particular topic because I would love to get everybody's feedback, but disorders of emotions or moods can also be a risk factor for heart disease, especially in women. And I did reference you all to the Women's Health Initiative study already. But in this one study, I thought it was interesting to look at, depression as a diagnosis and as an independent predictor of death, even if you have no prior history of heart disease at all. These women, almost 100,000, were followed from early age with no baseline heart disease and followed for 4 years. And they found that depression was an independent predictor of heart disease and all-cause mortality after adjusting for the social determinants of health and other risk factors such as diabetes and hypertension, or being overweight, physical inactivity, and cholesterol, the things that we talk about and that we talked about before as risk factors. So without any of these, having depression long-term is a diagnosis that can be associated with a higher risk of death, in fact, twofold. Now, I do want you to know that everybody goes through mood disorders at any time, but depression, ongoing, pervasive, long-term, where you have disorders of your autonomic nervous system, your sympathetic nervous system. These are the kinds of things that can drive abnormal, sort of reactions, abnormal hormones, abnormal, changes in your heart rate and in your blood pressure, changes at the vascular endothelium, elevation of, abnormal substances, TNF, tumor necrosis factor, and other things that can end up causing dysfunction of your vascular endothelium and leading to, a risk factor and potentially, hopefully not, but it can result in cardiovascular death. So depression and independent risk factor. The Stockholm coronary risk study also showed that, and I just wanted to share this as on a lighter note, that stress itself can cause recurrent or cardiovascular events and can increase threefold. Now, interestingly enough, living alone with and work stress in this particular study did not show an increased risk of coronary heart disease. And in fact, for the male partner, they're just being in a relationship is beneficial for them. But among the women who were married or cohabitating and they had relationship stress on top of it, this actually led to an increased risk of coronary heart disease. So I just wanted to point that out. And the very extreme of this could be something that is literally called broken heart syndrome. And so it can result in, an acute heart attack where you go to the cath lab and you see no coronary artery disease. You could see an abnormality of the myocardium that is not working, appears to have suffered a heart attack, and and not working. And if you're able to overcome the stress and you follow these patients, later on, their heart function improves. Another component is the Takotsubo syndrome, which is basically a cardiomyopathy relating to stress that relates to overall high levels of these dysfunctional hormones and other substances that causes a stunning or hibernation of the myocardium. The patient can present with heart failure and reduced function. A particular shape can be actually seen when you look at the echo. And so this term actually comes from, just the shape of what the heart looks like when the female has this type of presentation called Takotsubo syndrome. But, luckily, these types of psychosocial stressors resulting with heart disease are typically reversible. And, once getting over, the particular type of stressor, the heart function may return to normal. I just want to point out, also to know that, there can be some tests that are not as accurate in women. And so you want to make sure that when you're being evaluated that, this is recognized, and that if there are false readings, non-specific readings, et cetera, you want to have a better look. So for instance, looking at just say the cholesterol or the fasting lipid profile, it's important to look at the entire profile. So not just the total cholesterol, but the total breakdown. So the cholesterol, the HDL particularly, is very important for women, because having an HDL of 50 or greater is important. Having an HDL, though, that is too high, recent studies have come out that shows that the HDL molecule, if it's too high, 90, 100 or higher, then it's just one of the molecules that takes up a lot of space and actually prevents adequate blood flow. So having too high an HDL has now been, can potentially be a risk factor as well. So having an HDL somewhere between 50 and 90 is important. Having an LDL, so the LDL, as you know, by the American Heart Association, American College of Cardiology, without any obstruction at all, should be around 100 or less. And if you have any obstruction, so a positive calcium score, carotid Doppler, or any other evidence of a comorbidity that increases your cardiovascular risk, such as, very bad, diabetes or peripheral vascular disease, your LDL should be less than 70 and preferably less than 55. So for women, these are very important and it should be looked at. The lipoprotein A is a new molecule or of new interest that's being studied right now, that is usually genetically assigned. So it's either high or low, but it's important to know that it's what the number is so you can adequately address these other lipid moieties. The lipoprotein A is being studied very widely right now. There are no drugs to particularly treat that, but if you know that your lipoprotein A is high, then you want to make sure these other molecules are being addressed. The EKG is notoriously false positive for women. When you do just a regular stress test, a woman may have, depressions that are shaped differently. Typically, you want to look at a particular pattern of depression to truly be designated to be ischemic. And for women, the pattern may change. There may be an upsloping depression, for instance. And so that may be deemed as a false positive, or it be non-specific. And so the test can be non-diagnostic. So typically, if there's a very strong suspicion, the person should not just have a EKG stress test. They should have an imaging modality, such as a nuclear component or a echo component, particularly where the movement of the heart can be adequately and accurately interpreted. So for the echo, when someone is exercising, they're looking at the increased motion and function of the heart when exercising. And so they could look at specifically whether that area is improving. They can look at, high pressures within the lungs and other things like that. That would be helpful in determining whether or not the patient is experiencing a problem with the myocardium while exercising, independent of that EKG, which may be nonspecific. The same thing with nuclear imaging. So for women having, we have breasts, and so we may have what's called attenuation, where the radioactive dye may appear to be taken up in the breast, and there could be a false interpretation. So in the appropriate center, the women are adjusted, so they're flipped over, and the heart is looked at in both directions, so they could figure out whether or not the imaging is accurate or not. And cardiac cath itself can be very difficult to interpret in centers that are not adequately equipped to understand the anatomy of women. So on this next slide right here, we're looking at the cardiac cath of A would be more likely to be a male, and B would be more likely to be a female. So in a male patient, when they go to the cath lab, you may see a very specific stenosis. So here, I don't know if you're able to see, but so there's blood flow, and then there's a very specific blockage right here. If you look at the pressure flow curve below, you'll see a steep drop off. So if they do something like a fractional flow reserve, or they look at the pressure gradient across the vessel, you'll see that there's a steep drop. So this is an obstruction that's significant, and they would put the balloon, the guide wire, into this lesion, then they'll blow up the balloon and deploy the stent at this very area because it's very discrete. You can see that there's an obstruction here. Typically, in many women, they have diffuse narrowing. So across the entire vessel, you'll see that it's narrowed. So it doesn't look like there's any one particular area that needs to be dilated, because everything looks narrowed. So this could be misinterpreted as being a small vessel that's non-obstructed, and nothing is done about it, because they're not looking at the rest of the picture. So in this person, you'll see that there's plaque, the yellow stuff that goes all the way around the vessel. So the person has a lot of atherosclerotic plaque. They have diffuse narrowing. If you look at the pressure flow curve, you will see that there is a drop off, So this is an impaired artery right here. And so even though you can't deploy a stent because there's no one particular place to deploy a stent, this is a patient that needs to be treated. So they need to be on what's called GDMP, guideline-directed medical therapy, where they're on all the appropriate medications that need to be for someone to be placed on when managing coronary artery disease. So they'll need to be on the aspirin, the statin, maybe the beta blocker or a vasodilator, something like that, that would help that person in terms of managing the disease burden. So, just knowing that even going into the cath lab, it can look different between a male or female is very important for you to know, for yourself as a patient to advocate, but also for your healthcare provider. I just wanted to show a picture of what a stress echo looks like. And these pictures to the right they're not going to play, but pretty much what happens is you're doing the stress test. So there's an exercise physiologist there. There's a doctor in the room as well, but you're also taking pictures. So basically you do some resting pictures. So you see what the heart looks like when just resting. Then you have the patient exercise, and then they get to the bed as quickly as possible. You want to capture all the images within a minute, preferably no higher than 2 minutes, so that you can see that that appropriately all of the heart muscle areas are activating and pumping as they should be, augmented from exercising. If those images, if the views show that the heart becomes hypoactive or not moving, that is a sign that the heart is not getting blood flow, and thus you can, interpret it as not having, adequate blood flow. So probably a blockage or a drop off in pressure or something like that. So this is one of the best tests for a female, a stress echo. So when you go for a stress test, of course, insurances usually pay for just regular stress tests, but in many cases, especially if there's a high suspicion, what should happen should be a stress echo. Now, let's just say that that's not approved and you need to have further testing. Then other tests such as a calcium screening is recommended. And if you remember, I talked about during pregnancy, if there are risk factors to further risk stratify the person once they've had the child, a calcium score is very, very helpful. So, if you have a woman who has been identified and maybe at increased risk, if they get a coronary artery calcium score and there is a positive score, then that they have increased risk and they need to be managed very aggressively. Several studies have looked at this, but basically, there's one particular one looking at women who were actually quite young, with, you want to know what to do with their LDLs that are high. But pretty much it showed that women who had elevated calcium score along with an elevated LDL were more likely to suffer from a high risk event compared with others who are not. So this is something that's very important. A lot of times I just want to say that the insurance they won't pay for a coronary artery score. It's typically between $190 to $270 or so. But if you've gone to the doctor, you're concerned about your risk and you pass your stress test, but you may have a high risk, either having had an event during pregnancy, a family, history that's very strong, or you just feel that there is, some high risk, then they could do a coronary score and it would be very helpful. I just want to point out, I don't think I have a slide that shows that, if you have a negative, coronary artery score, a carotid Doppler, so a study of your neck is recommended. So we're seeing that, several women who have had a negative calcium score, but the suspicion is still high. You're trying to figure out, should I be very aggressive at lowering these LDLs? You do a carotid Doppler, and many women who have a 0 calcium score, you go on to find that they have plaque or hardening of the arteries in their carotids. And so, these patients need to be placed on a statin and treated to go. I don't probably have time to go through this. I'm going to simply say this basically corroborates some of the things we talked about before, where depression and anxiety, along with typical risk factors, actually played a role in increased risk for women, even from a very high level society without necessarily social determinants of health or anything like that. An independent risk factor that was actually shown in women was ongoing issues or conditions related to depression and or anxiety that actually, would result in worse outcomes. But in these women, they, basically initiated management of several of these issues. So not just managing their metabolic syndrome, cholesterol, and diabetes, but also, helping these women to basically engage in activities that reduced, that would contribute to stress or anxiety, and actually found that just adding that by itself resulted in improved other risk factors that we typically mention. So, basically you showed a significant reduction in some of these risk factors after engaging in components that address both metabolic syndrome and also allowed for stress reduction. Just wanted to point that out. And I'm going to just talk about quickly aspirin, because that's a big, because I want to have some questions and discussions afterwards. This is, people get sort of mixed results on aspirin. So I'm going to go back to, and this is an older recommendation, so to speak. But, some of these recommendations come and go. Right now, we know that an aspirin a day does not keep the doctor away. Aspirin in and of itself can cause issues related to bleeding, gastritis, GI related issues, just taking them every day if they're not indicated. So typically, you need to have evidence for taking the aspirin, not just taking it on its own to try and prevent things. So if you have coronary heart disease, this is a class 1 indication, class 1A indication for aspirin therapy, and women should be on a daily aspirin if they have had some sort of coronary heart disease, previous heart attack. They have evidence of atherosclerotic heart disease. If they have something like they've had a stroke or peripheral vascular disease, they need to be on an aspirin, a class 1A recommendation. Of course, unless they are bleeding or intolerant, in which case you can use clopidogrel, which is also Plavix, and which may be better tolerated if someone has a GI bleed or acid reflux or GERD, and that's a class 1A recommendation. For people with diabetes, it is reasonable. It's a class 2A recommendation, because diabetes itself is a coronary artery heart disease risk equivalent, which means that if you have diabetes, especially uncontrolled, over the next 10 years, you may be more likely to suffer from a cardiovascular issue. So in patients like that, it may be reasonable to consider aspirin therapy, unless, of course, if they're having some sort of issue. I just want to mention that for pregnancy, there's certain drugs to avoid. I recently had a patient, she had a some sort of congenital cardiomyopathy. So she had a weak heart that was in the 30s. She's been on aspirin. She also has high cholesterol, so she was on an aspirin, statin. She was on, an ACE or ARNI because her heart function was weak. She was married for about 8 years, seeing me, just to maintain her medication, always kind of very tired, but they were married. She wasn't expecting to get pregnant. And so about 2 months ago, when we were trying to adjust her medication so she could take some time off from work because she was tired, she called me, she said, Dr. Fergus, I tested positive for pregnancy. I'm like, okay, let's just make sure that this is really correct. This young lady was taking statin. She was on an ACE inhibitor. She was on a beta blocker, and her blood pressure was 180/106. That's very high. Okay, her lipids are uncontrolled. So her LDL was also very high. She had an A1C, so this is for diabetes, that was 11, and she was pregnant. Okay, so this is very, 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 very high risk pregnancy. Number one, there may be, something teratogenic as it relates to the fetus, but this is a patient who may be high risk for maternal death. So this is a case where you would want to have many different disciplines involved. So basically, I called an endocrinologist. I told her to get a high risk OB, basically getting a primary doctor. And then if she needed to have additional things done, she would need to get done. So she immediately had to get off the ACE or ARNI, but we needed to get her blood pressure down. So in her case, a type of beta blocker like labetalol. You can also give an old-fashioned medications like alpha-methyldopa or hydralazine can be used. So she needed all three. She needed to be on an aspirin. So someone like her, certain treatments for diabetes, you want to get their blood sugar down. So they can be on insulin and they can be on metformin. So she needed to get on that right away. In a case like this, the lipid is not that important, because, she was alive, or she's been around for 30-something years. The plaque is not going to grow that rapidly in the 8 or 9 months that you get that you're having the child. So she could do without being on a lipid lowering medication. However, statins are actually contraindicated. So she would have had to get off of it anyway. So her statin was stopped. She was placed on an aspirin. She was placed on blood pressure lowering medications that could be taken while pregnant, and insulin, and followed by all these doctors. So far she's managing, she's doing well, but she's high risk. So this is someone who you would have like a planned delivery, which would be a planned cesarean section. She would need echoes. So she had a baseline echo and already another echo sonogram. And, her blood pressures and all of that would be monitored. The reason for the echo is that the minute that you start to see any abnormality, like an elevated, pressure, pulmonary pressures, the baby has to be delivered right away, because that could be a death for the patient. But these things happen. But anyway, just to reinforce, statins, if you're planning to get pregnant and you're on a statin, it should be stopped about 2 months before getting pregnant. If you found out you're pregnant, you have to get off of it right away and just follow up to make sure, with the high risk OB, that you and your baby are okay. Avoid ACE inhibitors, avoid blood thinners, and NOACs. So NOACs would be like, something like Eliquis or Xarelto. And these patients are treated with heparin, so they would be treated with IV heparin or low molecular weight heparin. Other types of beta blockade, singular, beta blockade, or like a beta-1 selective, like a atenolol, and all those are not necessarily recommended, but you could use if the patient has tachycardia. The alpha beta blockers are preferred, like labetalol for blood pressure lowering. This patient, I think, also got labetalol. I just wanted to point out, because maybe some of you might be postmenopausal, is that, the thought, I think women think, estrogens protect me when I'm young, so this is something that we can take, when we get older. Well, for prevention of heart disease, no. You should take it only if you need it for some GYN related issue, and preferably topical or vaginal inserts, especially if you have some sort of heart disease. But taking certain, estrogens and certain hormones, female hormones, are associated with actually poor outcomes for heart disease in women. So should not be considered for primary use or primary prevention. And I had some cases, but I don't think we have time to go over that, because I want to take your questions. So here's my call to action for everyone right here. Are you aware of potential issues with your own heart health? So I don't care if you're 20, 30, 40, 50, or 60, know your numbers, know your risks, know whether you might be at risk. Some of the atypical sort of risk factors that one would normally think about, keep that in mind. And what are you going to do? What is your plan? What is your game plan to promote your own heart health? Because as you know, heart disease is 80% preventable. And your family, your friends, having a community, or, working with your community, as, you're doing right now. This is a community right here, helping each other in terms of maybe creating exercise, plans, having discussions, for emotional wellness type discussions that help to reduce stress is helpful. Working out together encourages people to exercise. That's a very good way of just promoting the community health. And, just making sure that there are resources available where you guys are for women to find out about their own heart health. So American Heart Association is always a good resource. The American Diabetes Association is also a very good one. NHLBI, also just looking at, resources for nutrition, exercise, and emotional health and wellness are all very good. So I'm going to actually end here, stop sharing, and happy to take any questions if there are any questions at all.
Oh, thank you so much, Dr. Fergus. We have a lot of questions in the chat, and some of them you could have addressed already as you were going, but some you might want to take if you want to look at the chat and select the ones.
Oh boy. Okay. Let's see. Okay, so let's see, oh, this is where you couldn't see the slides. One person's blood start to clot in a healthy individual. Is it hormonal? Is it stress? So yeah, great question. And to be honest, for instance, this young woman who had the pulmonary emboli, in retrospect, we're trying to figure out whether she had like a viral infection. So sometimes viral infections can cause people to be, quote, hypercoagulable. So, that's one of the things you want to maybe recall whether you had a viral syndrome. In particular, COVID was one of those viruses that could cause clots. And in rare cases, the vaccine itself can cause clots in a few patients. So that's one. If someone travels a lot, so, we wanted to find out from this patient, was she traveling a lot on a plane or in an enclosed space for a long period of time where she wasn't moving around? Because everybody forms tiny clots every day, but typically they're very tiny and they get broken up by the time they return to the lungs. But it's the large clots that are not breaking down that help. So, you want to, if you're on a very long trip, like a plane or you're a long car ride, if you've recently had surgery, so long car ride, plane, you want to get up and move around. You may wear compression stockings or socks. If you had surgery, typically they would put you on like either compression stockings, or they have various types of things that help to move the circulation. But, anything that would promote, long period of not moving. The other thing you want to do is rule out in these patients that they didn't have an underlying hypercoagulability that is something that's going on. So she was referred to a hematologist. For women, other conditions such as lupus or any other, sort of autoimmune disorders can actually cause you to have clots. Swelling is another reason. So what role does genetic testing play in screening diagnosis of certain heart conditions? Okay, yeah. So one of the young ladies that I referred to, maybe not that one, she also had a child successfully. The baby's now about 2 or 3 years old. She has a cardiomyopathy. And I always, when a young person presents with a cardiomyopathy that you don't know why, you want to get genetic testing because you want to find out if there's something going on. So you can refer very easily now for blood tests, a cheek swab for diagnosis. But in this one person, after questioning her, I found out that she had many male relatives who died at young ages, and they most likely had a certain genetic marker. So I had sent her for genetic testing. It turns out she had that marker, but it was carried more by males, so by the Y chromosome. Luckily, her daughter is free, the baby, of this condition, but she's not planning to get pregnant again because if she has a male child, she may have it. So yeah, genetic testing is important as for cardiomyopathies, things that may be lethal and sort of esoteric. But if you know that there's sort of a family history of, say, elevated lipids as well, or early, deaths from heart disease, you may want to also, do some genetic testing, especially if you plan to have children. Can you comment on how to monitor a female after chemotherapy treatment for associated heart or cardiovascular related complication years after treatment has ended? So first of all, if a female is going to be getting chemotherapy or radiotherapy, you want to establish a baseline echo to kind of see what's her baseline. Because when you repeat the echo, if you see a difference, you already know something has happened. So typically, I get a baseline echo, and then I get an echo either 3 to 6 months during the treatment. In the past, many of the chemotherapeutic agents were very, very well known for causing cardiomyopathies, like your adriamycin, daunorubicin, and things like that. And I don't think they use a lot of that anymore, but some of the chemotherapeutic agents can actually suppress your heart. So you kind of want to know that ahead of time. Radiation can cause coronary calcium, and it can happen later on. So, after, during chemotherapy and after chemotherapy within a year or two, you want to get a follow-up echo, and later on, you want to get maybe a calcium score carotid just to make sure that you do not have coronary calcium. That's important. At what age should coronary artery calcium screening be done if you have risk factors? So it can be done anytime. But the one thing is it remains one of those tests that typically your insurance does not pay for. So again, if you're somebody you're young and you've had certain risk factors during pregnancy, if you have a very high, lipid count, so high LDL, I use that a lot to figure out, do we get this patient treated more aggressively to try and get their LDLs less than 70 or just around 100? So, but now what I do a lot is I'll do a carotid Doppler, because remember I mentioned there are a couple of studies that show that, the carotid Doppler is a more sensitive test. And I have a number of women who their coronary artery calcium is 0, but I do a carotid and the carotid is positive. So many times if someone comes in and they have a very high LDL and they're like, I don't want to be on a statin. Today, I saw someone, telehealth, who 35 years old. I think the LDL started out at 124, got the LDL down to 107. Coronary artery calcium was 0, but 107. There's a family history of heart disease. We did a carotid Doppler. It's 0. So there's no at 37 years old, there's so far no plaques. The guidelines recommend closer to 100 if there are no, risk factors. But, this person wants to eat, they're kind of starving themselves, so they want to eat a little bit. I wouldn't recommend a statin on this person, but there are other treatments that can get the LDL closer to 100, because you don't have to get it down to less than 70 because they have no blockages. So yeah, you can always get a coronary artery calcium to kind of verify, and it doesn't matter what age you're going to pay for it, but a carotid Doppler, you may not have to pay for. I'm talking fast because it's 1 o'clock. I'm hearing transdermal estrogen can benefit postmenopausal women with low bone density. Yes. And for brain health. Yes. Is taking transdermal estrogen safe with regards to heart health? Yes, it can be. But if you're somebody who has significant coronary artery disease, then you got to work with both providers. And I've had that. The women, they're suffering from, osteopenia, osteoporosis, and, but they have, a heart condition. And that patient, we're, making sure their lipids are well controlled, that their A1C is well controlled, and they may be on an aspirin to kind of help. So, this is a patch transdermal. Also, this is better than taking, certainly you wouldn't want to take an oral, with that, because the patch is less likely to, contribute to a poor outcome. But you would work with your providers, especially if you have a big risk. Thank you. And familial hypercholesterolemia is common and inherited too. Absolutely. I mentioned lipids. I may not have said familial hypercholesterolemia, but that's one of them. And you do want to get checked for that as well. And I think that's it as far as the questions. And we're at 1:03.
Yes,
So
thank you so much for covering every single one of them, Dr. Fergus. And it was an amazing presentation. I personally learned a lot. Thank you for all of you who've been here with us. Be on the lookout for our next lecture in April on ADHD in women. And with that, I want to wish everyone a great day. Thank you, Dr. Fergus, again.
Thank you. Bye, and happy heart health, okay?
Happy heart health.
Bye-bye.